I am quite excited, Stoner Wizard, because, as you know, we have sought for millennia the treatment for stroke. The current potions we have, even the dark wizards are skeptical. But now there is light in the tunnel. Light, I say.
I think you two have officially lost your minds, but it is a pleasure to be back and wrap this up. So we're talking about thrombectomy in stroke. Are you ready? Merlin and Stoner Wizard dude.
We were ready 200 years ago, Doctor.
Bring it on, Dr. Mizuho. Come on.
All right, let's go. So as we mentioned, we are talking about thrombectomy for stroke. Now, traditionally, endovascular thrombectomy was supposed to be done in 6 hours from the last well-known time. And it's most effective, we know, in the proximal middle cerebral artery, or the MCA. And Rob, I'm going to have you be the MCA today. And Stoner Matt Wizard, you will be the ICA, the internal carotid artery. These were the two vessels that we found it most helpful in. And the question was that these authors wanted to ask was, could that 6-hour window be extended? So they did a randomized, multi-center, open-label trial. This was published in the New England Journal of thrombectomy plus medical therapy versus medical therapy alone. And this was for patients with an acute ischemic stroke. And they wanted that window extended all the way to 16 hours after their last well-known time. And then they looked to see how, much of the brain was infarcted. So in the study, they took 182 patients, 92 had endovascular therapy plus medical therapy, and 90 had medical therapy alone. We won't get into the nitty-gritty of it. You can look it up here. Now, this trial was designed so that it was randomly assigned 1-to-1 ratio. Randomization was based on age, core infarct volume, the time from onset, as well as their NIHSS score, and then their trial site. For the methods, the endovascular therapy group, this was performed by an FDA-approved device at the discretion of the neurosurgeon, and efficacy determined by the thrombolysis in cerebral infarction, the TISI score of 2B or 3 was used. So for methods for the endovascular therapy group, they allowed carotid angioplasty and they did plus or minus stenting. That was permitted, and all the other details we can sort of skip right through. Now, standard medical therapy was given to both groups, if you remember, and that was based on the current American Heart Association guidelines. So here were their outcomes. Now, in terms of efficiency outcome, their primary outcome, the ordinal score on the modified Rankin scale at day 90 was evaluated. And then they looked at the functional independence of patients at 90 days, as well as the safety outcomes. Here are the results. What happened? Well, when we looked at the efficiency results, the endovascular therapy plus medical therapy group had a more favorable outcome, both in terms of scale at 90 days and also just with the functional outcome at the end. If you look at the comparison at the bottom, 45% of patients did well with the endovascular therapy group versus 17% in the medical therapy group in terms of functionally independent at 90 days. Essentially, the two vessels that we looked at, right? We said the ICA and MCA, right? These two vessels were looked at for this endovascular treatment. And with endovascular therapy plus medical therapy compared to medical therapy alone, the combined endovascular plus medical therapy was really the one that did well. Mortality at 90 days was less, and their overall functional independence was greater.